the bloodless line of Borodell, relatively avascular longitudinal zone along lateral border, is lateral border. Most suitable site for surgical incision, but many vessels cross this zone. Planned radial or intersegmental incisions are preferable. Now, according to the pathological condition of the kidney, the incision has to be decided where to be made. Now, hydronephrosis. Now, this is the abdominal aorta, this is the renal artery, and in the superior pool there is a branch, and this is the 13%, 10%. This is the differences of different types of the blood supply of the kidney. Now, accessory vessels to the inferior pole cross the anterior to the ureter and may obstruct the ureter. This is the, it goes in the anterior part, and the ureter is like balloon, like it's compressed by this artery, urinary obstruction, artery causing urinary obstruction. Now, aberrant renal arteries. You see the aberrant renal arteries. Now, that's why you have to, for any condition of any, you are suspicious or you are have a diagnosis of, you have to do an IVU plus KUB plus your USG. Now, referred pain. Now, sympathetic, see, this is the sympathetic. Now, renal, gonadal, and superior hypogastric plexus, preganglionic fibers T10 to L1, loin to groin, parasympathetic, vagus, pelvic splanchnic nerves. Now, this is an important when the patient is coming up with ascending pyelitis or a urinary stone or acute pyelitis, then the loin to groin. You ask যে পেছন থেকে আপনার ব্যথাটা কি এই নিচের দিকে নামছে ব্ল্যাডারের ওখানে গ্রয়েনের ওখানে, if she says yes, then you see the patient, tell him or her to sit up and you press in the renal angle. But clear cut, when you go and visit the clinics, then you will observe patients with renal colic and from loin to groin. Now, the previous days even I discussed the ascent of the kidney and its rotation. Now, you see the suprarenal gland, this is the mesonephros, the hilum of the kidney, the renal artery, left kidney, this is right kidney, the ureter and the bladder. And this is the ascent of the kidney. You see the suprarenal gland. Now, the gonads, these gonads, hilum of the kidney, mesonephric ducts and ureter. And the suprarenal gland, this kidney is here at this level, ascended, and sites of the former renal arteries. This is the site. Now, the gonad is here. In case of males, it descends. The incomplete descent of testes I have discussed, and the testis goes down to the scrotum. Now, developmental anomalies, according to number, agenesis of one kidney, multiple kidneys. According to position, pelvic kidney, fused kidney. According to shape, horseshoe kidney, pancake kidney, polycystic kidney. Now, usually nowadays it's very common that due to the reports of the ultrasound, actually things are more diagnosed. And sometimes in the USG center, you are told, Dr. Amar ki hoyeche, what has happened to me? They got a cyst hoyeche. Now, পেশেন্ট মাথা ঘুরে গেল, টাই টাই করে ঘুরতে লাগলো। হ্যাঁ, হি অর শি ইজ হ্যাভিং ভার্টাইগো, সিস্ট হয়ে গেছে কিডনি, নাও polycystic kidney. Now at that time, how you will tackle that patient? Say you now if it is polycystic in the left kidney and right kidney is okay, then you just see the patient is accompanying a person with her. Then you tell, just give an example. What I do in my clinic is that, see this, your one kidney is bad. So kidney bad bolte ki it is not harmful. If it is a polycystic kidney, occasionally there is hematuria, blood in urine, that occurs. So you, when you're taking the history of the patient, then you ask her the question that do you, any blood comes out during micturition, during urination. Then if she says no, that's not this thing, then you have to still, that block is there in the head. That a polycystic kidney, I am having a polycystic, I have a big this thing, kidney disease. So you tell that, see, this gentleman, it might be husband, it might be his father, or her father, or a mother, whatever, who is the relation with, you tell him that he is having one kidney, some pathology in one kidney, pathological kidney. Then if the patient is having this polycystic kidney, she will, psychologically she gets banged actually. So you just say that your father or your husband, you are going to have a kidney transplant. It's just an example to make her psychologically come out of the block. So if he donates one kidney to save you, then how many kidneys does this gentleman will have? Only one kidney. And how many kidneys you are having? So I'll have 2 kidneys. Then it's okay. But he'll live with 1 kidney, but you'll be living with 2 kidneys. Then she smiles and anyway, she's assured that it is not an issue. Anyway, next. Now, developmental anomalies, unilateral agenesis of pelvic kidney, bifid ureter, okay, and malrotation, bifid ureter, and supranumerary kidney, cross renal ectopia, discoid kidney, and supranumerary kidney. These are the, you'll get it in the embryology books. These are the condition, and this is the bifid kidney. Now you see, this is the inferior vena cava. This is kidney, one kidney. This one is suprarenal gland, and the bladder is here. You can get to the 2 kidneys are there, but the bifid ureter is here. And double kidney, here's double kidney, complete division of ureteric bud, complete division of the ureteric bud, and suprarenal gland, discoid pancake kidney. This is a discoid pancake kidney, and the short ureter into the bladder. Now fusion of kidney here. Now you see the supernumerary kidney here, 2 ureteric buds, and left kidney migrated to right, that can occur also. And see, left kidney migrated to the right. So this can be evaluated with a intravenous urography, IVU. You can see, but 2 different, the IVU plates, radiological plate in the department. If you see, these are normal kidneys with an intravenous urography, but if there is a film or patient comes with, then you see here, there will be 2 kidneys, and the left is it is not there. The left is migrated to the right side. Now these are the fused kidney. Again, suprarenal gland. This is supernumerary kidney. So the double kidney is due to your two ureteric buds, the kidney buds, double kidney, complete division of ureteric bud. Now, see congenital anomalies, the adrenal gland, and see here the left vena cava, the aorta, and this is the ureters, and this is on the left. Now, renal artery, inframesenteric artery, this is the ureter, and see this is a horseshoe-shaped kidney. Now, this is a fetus which has been dissected, and see the kidney, fused kidney, the ureter is here. It's from the fetus that is, they have dissected and presented. Now, aberrant renal vessels, see the different, the renal vessels, and see left suprarenal artery, left the polar renal artery, and you see that this can occur. At times you will see when you dissect the dead bodies, and you try to locate the kidney, try to dissect out the blood supply of the specific kidney, right or left. If there is any anomaly you find, take up a photograph and you bring into the notice of your teacher, so we can have it as a specimen in the department, and also you can even present a paper on a later when you want to. Now, now this is the double ureter. See the ureter here. This is the ureter. This has been sliced, you know, the kidney is opened and sliced. So you can see this is the surface and that is the inner surface. This is the inner surface of the kidney. Next. Now polycystic kidney. Now numerous cysts appear in the substance of the kidney, usually bilateral. Commonest of all is anomalies. Takes place due to abnormal dilatation of the different parts of the universe tubules. But that is normal tissues are there also. So in an IVU, you can get a picture like this. So when you are getting a picture like this, is diagnosed as polycystic kidney, but ultrasonography gives you a picture. So you have to decide according to the condition of the patient's complaint. You have to decide you will go for an IVU or not. But it's institutional, like a medical college. You must go do KUB, kidney, ureter, bladder, plain radiograph, and then one number. Second number, USG. Third, IVU. And if there's a mass, any kidney tumor, then you have to go for a CT for more detailed evaluation. Next. Now, ureteral anomalies, ureteral fistula. This is the median umbilical ligament, the ureteral cyst, and urinary bladder is here. And sympathetic fibers, the urethra. Now, ureteral sinus, and now it can, in the ureteral fistula, the patient comes that something is, it is, I feel some watery discharge over here and I can see it. But when you are examining, you take a piece of cotton and then you just wipe and press the bladder like this, and if you see it's coming out, but it is a sinus, that is, will be small amount will come in. Blood, like if you take a balloon filled with water, you open the thing and press, it goes. Okay. It is not like that. Now, you have to do one thing, smell. So you take the, you wipe the umbilicus with the opening and then you smell. ডাক্তারি করতে গেলে তো স্মেল করতেই হবে একটা any pus you smell what type of infection, what if there is a after an operation, if there is one say drain, you're given a drain there, your boss has given a drain, if some anastomotic operations of the colon or GIT, then you see if it is a stool, if it is a stool or not. So you must smell these conditions and then go for an USG, and this is a simple operation of repair. Next. Now the congenital rectovesical fistula, incomplete development of the urorectal septum. Congenital vesicovaginal fistula, Mullerian eminence projects into the vesico-ureteral part of the cloaca instead of urogenital sinus. Ectopic vesicae, anterior wall of the bladder is deficient and interior of the bladder is exposed. So this is a common finding. Common means every 100 birth you will get a ectopic vesicae, is not that. But nowadays due to anomaly scan and this type of imaging, things are detected earlier. So you have to, ectopic vesicae, anterior wall of bladder is deficient and the inferior bladder is exposed. Next. Now see this diagrammatic representation of the urinary bladder. See the uterus and the vesicovaginal fistula, the vesicovaginal fistula. This is the sagittal section, this is the vagina, and this is the rectum. Now, if a lady comes with the baby that some watery discharge is from the vagina, then you have to diagnose that baby, what are the problems might be. So accordingly, you don't take things for granted, because these are the small issues. I wouldn't say small issues, but I would say rather big issues. If you, oh, it's all right, you are in a hurry and you are not looking into things, then you miss many things. And you misguide the parents of the child. Even it happens that you are not an expert, you are just a medical officer. But your things count, that you refer to some pediatric surgeon who are doing urology. So you, in this medical college in future, it might happen that you have to, you have a very good, brilliant pediatric surgeon. Then you send it to him and you get it corrected. এটা পরীক্ষা পাস করাটা ব্যাপারটা নয়, ডাক্তার এটা তো তোমাকে শিখতে হবে। What the mind doesn't know, the eyes cannot see. Now see, but these things occur, but nowadays due to modern investigations, they are early detected and you can, accordingly you have to manage that case. If you are not managing, manage the case means you manage, I don't like the word manage, oh manage করে নেব, এই তোমাদের একটা আইডিয়া হয়ে গেছে পরীক্ষাটা ম্যানেজ করে নেব। But I'm telling in the sense of management of that patient. Now see the ectopic vesicae here. The anterior abdominal wall is not developed. Naturally the bladder is exposed. I have a collection of congenital, different types of congenital anomalies. I will show you someday. Now, development anomalies of the kidney, agenesis of the kidney, multiple kidneys, pelvic kidney, fused kidney, horseshoe kidney. Just a repetition. Next. Now you see the major content is due to the congenital anomalies. Still, it might be that after all investigations or the anomaly scan, but all anomaly scans are not detected. It might be 40–50% is detected. So these anomalies, after delivery of the child, you are doing duty in the labor room, the gynae ops department. Then after delivery, you see if the rectal opening is there, anus opening is there. Has the child passed urine? You ask the mother or the attendant. Then accordingly, you have to be, hoye jabe, jol khawan. So, no, you look into it. And when the baby is delivered by cesarean section or by normal delivery, you please look at ulte palte dekhe nebe. Then you can see and put a note in your ticket that this child is born with no anal opening. Now what you do, you just give an order for an X-ray. And X-ray now, it can be like this. Now, this can be a skin and membrane only. Okay. Now, what you have to do is put a coin over here and take a radiograph, plain X-ray. Now, you can see if the distance between the skin or if it is, and also what happens in this condition. This is the buttock, and now what happens? Now there's a bulging like this, as membrane. You can just take a radiograph with a coin, so you can make the difference between if it is high up, away from the, say 1 inch, 2 inch, away from your anal opening, the skin. Now, what usually happens, it is if it's a membrane or this thing, you make a small incision, you send it to the pediatric surgeon, and then what he does, according to that, he evaluates and then makes a small incision, stools come out. But if it is high up, then he has to go for an operation. Now, the accessory renal artery, single kidney with 2 ureters. See, this is single kidney with 2 ureters. Floating kidney. Okay. Now, unilateral agenesis, pelvic kidney, bifid ureter, malrotation, bifid ureter, cross renal ectopic, discoid kidney, suprarenal kidney, EF. These are the. Now, this is again a repetition. Again. Applied anatomy, renal transplantation, lithotripsy, systemic hypertension, stenosis of renal artery. So, if a patient is not responding to your antihypertensive drugs, then think of that it can be in systemic hypertension, stenosis of the renal artery, that the patient requires a surgery. Now, kidney, ureter, bladder, this is the KUB. The most commonly a plain radiograph of the kidney, ureter, bladder. This is from this level to this level. Full plate. Then you will be just, the patient should be prepared with some digestive laxatives and now kidney stones. This is Staghorn stone, the large calculus occupying the collecting system of the left kidney and assuming its shape. Staghorn calculus. About 85% of urinary calculi are visible on the plain film. So 80% are visible on the plain KUV X-ray. You don't go for a CT, don't go for an MRI. You have to know when to prescribe, what to prescribe for radio diagnosis. Next. Now, calcified adrenal glands. These are the calcified adrenal glands. Next. Applied anatomy of urinary bladder. Women are more susceptible to urinary tract infection than men in cystitis. Urethral injuries are common in men than in women. Suprapubic needle puncture, suprapubic cystostomy, patients with stones in urinary bladder, pain in the hypogastric region worst at the end of the micturition, pain in the relieved on the lying down, and few drops of blood at the end of micturiation. Now, see, women are more susceptible to cystitis, and it's a botheration also. One thing is that intake of water in men, I would rather say human beings, that we are drinking water in bottle. So we drink beer in bottle, whiskey in bottle, but in our Indian marriages, every woman from their house are given a big ghora and pitcher, big glasses, two for the boy and also for the girl. But what we are drinking, you are just quenching thirst. You take a, jolta deto, ekটু খেয়ে নিলাম। বোতলে কি হচ্ছে, you are just quenching your thirst. Quenching with just ekটু গলা দিয়ে নামলো আর কি। But when you take it in a pot or a glass, you have water in your this thing, but put it in a glass of and then drink. You see the difference. I tell my patients, hey, তোর বিয়ের গ্লাসগুলো কোথায় রে? In your marriage, the glass who was given to you, where it is? ওই লফটে তোলা আছে। আমরা কার জন্য? বলো বৌমার জন্য বা মেয়ের জন্য। আমরা তুই নিজে বাঁচ, তবে তুই মেয়ের বিয়ে দিতে পারবি। So you have to drink water. That's why I'm telling you, hydrate yourself during this summer, and also in winter there is more dehydration. Winter there is more dehydration, and complaint of cystitis or urethritis is due to intake of water is insufficient. Okay, next. Urinary incontinence, lack of voluntary control over micturition, normal in 2 or 3 years old because neuron sphincter muscle is not developed. Stress incontinence in adults caused by increase in abdominal pressure that results in leaking of urine from the bladder, coughing, sneezing, laughing, exercising, walking, injury to the nerves, loss of bladder flexibility or damage to the sphincter. Now, this is actually when you take, say, a lady with a uterine prolapse of the uterus, then you ask her, you can control your urination? Or nah. By the time I go reach the toilet, there's some drops are there. So that might be due to acute cystitis, urethritis, and also because the bladder actually happens what in prolapse or cystocele, first degree, second degree, third degree, according to the severity of the prolapse of the uterus, then there is even some urinary incontinence. So accordingly, if it is, she's complaining of cystitis, also urinary incontinence, you have to give some, you have to give alkali and also plenty of water to drink, fruit juice to drink, and also some drugs. There will be antibiotics and to control. There are some modern drugs are there, and accordingly you give the urine for routine culture and sensitivity. But by the time the patient comes to you, she has taken some molecule, some drug from the shops. But yet you have to do, because sometimes the drug that is given to her might be resistant. So at least you can identify what are the antibiotics which is sensitive. Next. Cystometrogram. Next. It is a curve which studies the relationship between the intervesical pressure and volume. Method, it is done by inserting a catheter into the bladder to fill an empty bladder by water, and through special transducers, the intravesical pressure is recorded. First, the bladder is emptied from urine and the pressure is recorded. Then the bladder is filled with 50 ml water and the pressure is recorded for every in the volume, the increase in volume. Next. Now, this is the setup. This is the bladder, infusion pump, pressure transducer. This is in graphs, that is flowchart recorder, and filter amplifier. Next. Now, you can see cystometry. See 2A catheter. The catheter is introduced, and you see infusion line, water pump, extension set of two pressure transducers, and balloon catheter. Next. The urinary bladder, change in opacity, mineral cystic calculi, air, emphysematous cystitis, iatrogenic. Next. Now, applied anatomy of the ureters. During hysterectomy, ureter may be injured. You can see here in pelvic dissection and ligation of gonadal vessels here. Now, in this is the relation where the left ureter is more closer to the uterine artery and uterus. So, you have to see and dissect and then clamp and cut and ligate. So, it might be that you are ligating the bladder and the uterine artery and also the ureter. So, now utero-uteric anastomosis, now transplanted into the ileum or sigmoid colon. Now, sometimes these ureteric injuries, the ureter is transplanted in the ileum or the sigmoid colon. So, every time she goes or he goes for to the toilet, then it will come through the rectum anal canal. Next. Now, sites of anatomical constrictions of the ureter. This is important. Sites of anatomical constriction of the ureter. Now, pelvic-ureteric junction, renal pelvis joins upper end of the ureter. Pelvic brim crosses common iliac artery. Uretero-vesical junction, ureter enters bladder. Sites of arrest of ureteric calculi. Two more sites at juxtaposition of vas and the broad ligament, and other at ureteric orifice. Now, this is a very important, you will be seeing, and you have to accordingly manage. And the size of the calculi when it's going, it can be in these constrictions that it might be lodged. But with size of the calculi less than 1 centimeters, it goes down, it comes out. And there are some antispasmodic, some even Ayurvedic medicines that you give, and accordingly it takes time, but it works. It doesn't work nahi hai. But your size of the calculus accordingly, then you have to go for an operation. Now, constriction of the ureter. Third is the narrowest. This is the bladder entrance, constriction at this. This is the pelvic rim. This is the constriction in the kidney hilum. If there is a short note, then you just draw this diagram. If you have time, make the kidney like this. But these are the three sides of the contraction of the ureter. Third is the narrowest developmental, two fusiform dilatation in the embryo life, pelvic and lumbar. Next. Applied under ureteral, ureteral stricture. Usually, when this is detected, then in the pelvis of the kidney like this is a constriction like this. Then what happens? It is cut off like this, and then this is the position like this, and this constriction is released, and over here it is anastomosed. The lower end is anastomosed. This is a কেটে জুড়ে দেওয়া, কাটলো জুড়ে দিল। Now, post-operative obstruction of the ureter with subsequent kidney damage. Normal anatomy is this, and see the post-operative, this, if you are seeing the urinary output, that's why whenever major surgeries related to the pelvis, mainly most commonly performed is abdominal hysterectomy or vaginal hysterectomy. Now, if this is done, in the OT, the patient is taken after urination, she passed, then she is catheterized, and you see the volume of urine, how much during the operation period. It can be half an hour, it can be 1 hour maneuver, and then you note that. And then you empty the uro bag, and then you send the patient to the ward. After 2 hours, you again check how much urine is there. If you feel that the desired amount is not coming, then you have to see and bring it to the notice of your boss. So, যখন তুমি ওয়ার্ডে রাউন্ড দেবে, you just see কতটা পেচ্ছাপ হয়েছে. Your attendant, the ayas, you ask them to how much urine, note down in the bedhead ticket. এগুলো এটা প্র্যাকটিসের মধ্যে আসতে হবে. When you go to the clinics, you have to bring it into a habit. এই সকালে উঠলে ব্রাশ করলে, সকালে উঠলে গান শুনলে, তারপরে পটি গেলে, তারপরে ব্রেকফাস্ট করে ছুটলে লেকচার দিতে বা জবে, তো সেই রকম এটা হ্যাবিট নাকি। একটা ছেলে স্মোক করে, এটা আবার একটা লাগিয়ে আর একটা স্মোক করতে লাগলো। তো ইউ হ্যাভ টু মেক ইট আ হ্যাবিট। নাও applied anatomy, this is the normal, valves close, ureter bladder, and reflux. If there is a reflux, valve remains open, and you see refluxing urine in the back. Next, hydronephrosis of the kidney, hydroureter. Now, if a stone is lodged here, now what happens that the urine is not passing? That is, in the USG, you will get a report, non-obstructive calculi. That means the urine is passing side by side. এরকম একটা স্টোন আছে পাশ দিয়ে, ঠিক আছে? But if obstructive calculi, now this is, then this balloons, it becomes a hydroureter plus the kidney, hydronephrosis of the kidney. Now this is a calculi. Next. Now applied anatomy, urolithiasis, kidney stones, ureteral stones, bladder stone, ureteral stone. You will encounter in every this thing, these are the stones. I mean the whole the urolithiasis. Now this is a kidney stone, ureteral stone, bladder stone, ureteral stone. Now it happens that in male, sometimes it comes down, and the urethra, benign part of the urethra, or in the corona grandis part of the urethra. So simply you have to relieve that patient. So you make an incision, small incision, take out the calculus and repair and put a catheter. If it is within the shaft of the penis. Or yes, I mean a straight line there. It can be here, it can be here, it can be here. And if it is stuck over here in the meatus, then you can make, under local anesthesia, you can make an incision here and take it out, put a catheter. Okay? Over here similarly, and keep that catheter for 21 days. It definitely relieves the patient, and also it's a surgery performed under local anesthesia in an emergency. But nowadays, in a medical college, of course, you have to go according to the protocol. But if you are in the hill or some place, you send, there is communication is there. Some ambulance, helicopter ambulance in AIMS are there, Haridwar to, in Assam, Guwahati, AIMS. They are having all this, but this facility is very much less. You don't have a proper ambulance in the planes also. So, but you can see, if you are knowledgeable, you can send your papers to the higher center with all illustration and things to be done. So you are not taking exam of the guy who's posted in the hospital. You give a clue that this is the finding we have got, and furnish that paper. Your referral is that 2 to 3 patients in a day, or 10 patients in a day. So 10 patients, you are seeing 80 patients. But these 10 patients, you give a good, what are the findings and what is, then they will manage immediately. They won't go for any unnecessary investigations. Next. Now, benign hypertrophy of the prostate compresses the pre-prostatic and prostatic part of the urethra. The median lobe, when enlarged in old age, acts as a ball valve to obstruct outlet of bladder with eventual retention of urine. So when patients exert more straining of the picture in the urine flow is more diminished. Joto kod debe toto bond hoye jay. Ever next. Now enlargement of the prostate hypertrophy, neoplasia, prostatitis, abscess, paraprostatic cyst, and mineralization. Next. Now, Batson's venous plexus, a few prostatic veins pass backwards through the anterior sacral foramina and drain into the internal vertebral venous plexus. This is known as paravertebral veins of Batson. Now, backflow of blood into the Batson plexus takes place during increased abdominal pressure such as coughing, micturition, or defecation. This is a potential route of vertebral deposition of metastasis in cancer prostate. If a short note comes on Batson plexus, then you have to give all these points. That in prostatic cancer, metastasis in the vertebral column. Next. Now, prostatitis is inflamed prostatic tissue. Next. Prostate gland, anterior lobe, posterior lobe, the urinary bladder, median lobe, prostatic ureter, capsule. Next. Now, benign prostatic hyperplasia. Benign prostatic hyperplasia, BPH, is the enlargement of the gland. As the prostate starts to enlarge, it exerts pressure on the walls of the ureter. Next. See, early BPH, moderate BPH, and fully obstructed ureter. This is a bladder stone. Advanced BPH. Next. Carcinoma prostate. In simple hypertrophy, outer zone is compressed by growth and internal capsule acts as a surgical capsule which helps in enucleation of the hypertrophied mass. Prostate specific antigen, PSA, prostate specific antigen, most commonly done normal up to 4 mg, BPH 4 to 10 ml, CA prostate above 10 mg ml. It affects mainly the lateral lobe. Next. Now, prostatic cancer. This is a normal prostate. This is prostatic cancer. Next. Now, Gallison score, the poorly differentiated. This. Next. Prostate seed implant. Next. Prostatic brachytherapy, treatment for malignancy. Next. Prostate biopsy. See the ultrasound probe and needle guide. Take the biopsy of needle biopsy of the mass. Close-up view of the prostate. Next. And the pre-examination of prostate. Now, digital rectal examination with doctor's finger extended to check the position of the prostate gland palpable from the rectum. Now, in the ultrasonography, you will get an image of the prostate gland. It is enlarged, they will describe you, but you do a rectal examination. You take gloves, put some Vaseline or Xylocaine, and you put your finger in the rectum and see the structure, if it is smooth or if the growth is there, then accordingly you must do a rectal examination. When you go to the hospital clinics, you examine these patients because you don't depend on the directly, you feel the what is the growth, how it is it's spread or not. Next. Now you see very landmark of TURP, transurethral resection of prostate. Now this is the picture you will get. Next. Transrectal prostate ultrasound. Now like TVS, transvaginal, for see you doing USG in pregnancy. If you are suspicious of ectopic pregnancy, then you do a transvaginal ultrasound. The ultrasound in transvaginal, vaginal, the probe is put in, and they see the pelvic wall, if there is any growth in the ovaries, and if any suspicious lesion or any ectopic pregnancy.